Good afternoon, everyone. Welcome to your session on paediatric cardiac arrhythmias. My name is Brian McCrossan. I'm one of the paediatric cardiologists here in Belfast. Just an overview of paediatric arrhythmias. They can either be too fast or too slow. Within tachyarrhythmias, the easiest way to classify them is into narrow complex or broad complex, which for the most part corresponds to supraventricular tachycardia compared with a ventricular tachyarrhythmia. But we'll talk through some of the subtleties of that as well. When they're too slow, is there sinus node dysfunction, something again in the atria versus something at the AV node or below? This is really just for your reference. So types of supraventricular tachycardia, what we mean are any arrhythmia which is fast and originating at or above the AV node. And they can be automatic or they can be re-entry. When we say automatic, what we mean is that they are under the control of adrenaline and therefore they warm up and cool down, whereas re-entry tachycardias tend to turn on and turn off. So re-entry tachycardias can be within the atria, like atrial fibrillation or atrial flutter, or they can involve the AV node. And when we think of SVT, really what we usually mean is AVRT, atrioventricular re-entry tachycardia, which goes along with Wills-Parkinson-White syndrome, or atrioventricular nodal re-entry tachycardia. And that's more common in the second decade of life. AVRT would be by far and away the most common type of SVT in children under the age of 10. The least common of these is permanent junctional reciprocating tachycardia. I only put that in for reference. You're unlikely to come across it. And in the automatic tachycardias, sinus tachycardia is by far and away the most common, but it's also important to understand and to appreciate ectopic atrial tachycardia. So just to get straight down to some clinical cases, you're in the emergency department and a 5-month-old baby presents with a 48-hour history of pallor, shortness of breath, and poor feeding. And like everything in infants, it's all to do with the feeding, as being as being an important sign and symptom of things. So looking at the ECG, you can see that it's fast. It's going about 230 beats per minute. It's regular. For the whole, on the whole, it looks narrow complex. In V1, you get the impression of some intraventricular conduction delay, but on the whole, it looks narrow complex. And looking closely at it, it's difficult to see definite P waves as well. So you would think to yourself, well, it's over 220 beats per minute. That's a good rule of thumb that tachycardia over 220 beats per minute is much less likely to be sinus tachycardia. And the patient's symptomatic and it's narrow complex. This is likely to be atrioventricular re-entry tachycardia. And we'll come to the treatment of that a bit later. Whereas a 7-year-old boy comes along, he's been feeling dizzy, which he had one episode of that, and he still thought he would go to the emergency department. But you do his ECG, and you see this, and what you can see is that it's in sinus rhythm. There's a P wave before each QRS complex, P, 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 P. The rates, 1, 2, 3, 4, 5, maybe somewhere in the high 60s beats per minute, so a little bit on the low side, but it's okay. But what you do notice is that you have a short PR interval and sloping of the QRS complex. So this is barn door WPW. But has this caused his presyncope? Well, I think at the age of 7 or 8, you probably could give a reasonable history of palpitations if this was causing the presyncope, i.e. the presyncope in the setting of WPW should be caused by SVT. WPW by itself is not going to cause many symptoms. So it's not that this patient needs any immediate treatment or brought in to hospital necessarily, and I'm sure an outpatient Holter monitor and referral to paediatric cardiology would be enough with some safety net advice. Whereas in this instance, we have a much more abnormal looking ECG, and the history itself, an 8-week-old baby goes along to their GP for their vaccines check. For their vaccines. And when the GP checks has a listen to the heart, he feels that it's irregular and it's very fast. And indeed, he is right about that. So you can see that at its fastest, there's about one box between the two RR intervals, and so you're talking about a rate of close to 300 at times, but it is irregular even when it's fast. It's not just as fast here, and it slows down to considerable extent here, maybe 130, 140 beats per minute. But as I said, it's irregular. It's narrow complex though, and you can see some P waves going on here as well. So it is a tricky one to figure out exactly what's happening here. So what would help you make the diagnosis? Well, you're on the narrow complex tachycardia end of things. Is it sinus tachycardia? Is it atrial fibrillation? Very uncommon. Atrial flutter, possibility. Is it atrioventricular reentry tachycardia? A bit less likely considering that it is irregular. So what could it be, and what would help you make the diagnosis? Well, you could give a dose of adenosine. You were sort of itching to do that anyway, probably. But adenosine in this case here is not going to be therapeutic, but it might be diagnostic. By blocking the AV node, you've uncovered the atrial activity. And what we can see here are 2 P waves for every QRS complex. So what we have is an ectopic atrial tachycardia, and you've induced 2-to-1 AV block by giving the adenosine. So the difference between this and atrial flutter would be more likely not to give you a gap here. It would be constant atrial activity, much more sawtooth. So this patient will go back into an ectopic atrial tachycardia after a few seconds, having given the adenosine, because the adenosine will not treat the ectopic atrial tachycardia. It will just block the AV node. Next case, you have a newborn baby who pitches up to the emergency department who's very sick. They're edematous, they're poorly perfused, and there's not much history to be had from the parents here. There was no antenatal care. And what you can see here is, again, irregularity in the heart rate, but at times it's very fast, 300 beats per minute, and it's narrow complex. So we're on the narrow complex part of the tachycardia algorithm. But you can see here constant sawtooth atrial activity. So this is atrial flutter with a variable AV block. The reason why these patients are often very sick at time of presentation. So it's an uncommon, but it's more common than you think in newborns, because this is the one time when it's likely to present. And actually, the treatment at the newborn period is likely to be curative, but they can be very sick because this, especially in the newborn period, this is likely to have been going on for hours, if not days on end, antenatally. And because the placenta does all the work, or most of the work for the heart and the lungs, they cope with that okay. But then when they come out, they're not able to cope. And indeed, they may already have been the heart and cardiac function may already be relatively poor during fetal life. But the treatment for this is a DC cardioversion. Synchronized DC cardioversion is basically curative for this, and you would put them on. I like to put them on digoxin afterwards. This is just for your reference again, but I found this very useful in terms of differentiating the different types of SVT. So what is the treatment? So you've recognized the rhythm, you've looked at the patient, and the first question is, what is the rhythm? So you've no problems with that now. Second question, well, what antiarrhythmic do I give? That's not the second question. The second question is, how urgent is the treatment? Is there evidence of shock? Less than that, is there evidence of congestive heart failure? The patient got a few symptoms, or are they actually very well looking? How long have they been in SVT? These symptoms and the patient's condition will be determined by the duration of the SVT, how fast the heart rate is, and especially if there's any underlying congenital heart disease, or if they've got cardiac dysfunction as well. So the initial treatment is covered very well by the APLS guidelines, and so I've provided those there. So whether they're in shock, whether they've got congestive heart failure, whether there are no other symptoms and they're well looking, all of those eventualities are covered by the APLS guideline. Of note, in terms of vagal maneuvers, in an infant, I would certainly try an ice pack to the face. It's worthwhile, actually, if you can go and see that being done by somebody who knows how to do it. Because if you just set the ice pack on the face, it'll do nothing. You actually really need to smother the patient, but obviously you can't be too enthusiastic about that. Otherwise, you might, A and B come before C, and you might cause more harm than you intended to. But actually, it's something once you've seen it being done, it's not difficult to do, and it can be as effective as adenosine. Other vagal maneuvers, which I'm sure you're well aware of, would be popping your ears by covering over your nose and trying to blow out your ears. Doing a handstand is a less well-known one. Drinking something very cold or an ice lolly, or blowing through a brown paper bag, something, or through a straw, something like that. But you come to hospital for some medicine usually, and in most cases you're able to get IV, and if not, IO access pretty quickly, and you're going to give adenosine. Now, you try to get IV access as close to the heart as possible, and you put a 3-way tap on, and you give adenosine 100 micrograms per kilogram per dose, with attached up to a 3-way tap with a bolus of normal saline, and you follow the adenosine with the normal saline immediately, and should be on ECG monitoring all the way through that, and the ability to print out the ECG as well. That's really, really important. So that doesn't work, give it a minute, and then give a higher dose of adenosine, 200 mics per kilogram, and if that doesn't work, up to 300 mics per kilogram. If that doesn't work, you should pause at this stage and just make sure, A, that you're giving it properly and that you've got a decent line in. But if you're happy that you are doing those things, then is it really SVT? Especially if there's some aberrancy. Indeed, is this ventricular tachycardia that you're treating? Or maybe you need, the heart's quite refractory to it, and you need some baseline medication in there, such as beta blocker, digoxin, amiodarone. But at this stage, you should pause and think to yourself, well, I should contact pediatric cardiology for further advice. Whereas if you're on the shock side of the algorithm, then if you have IV access, or it's very, very quick to get that, or get IO access, yes, you can give adenosine, but you may be moving quite quickly down to a DC cardioversion, which obviously, very importantly, has to be synchronized. So the aim of treatment in SVT is to get back into normal sinus rhythm and to stay in normal sinus rhythm. If you can manage that, the patient will get better. A little bugbear of mine is constant questions about what dose of adenosine should I give next. If adenosine has even very briefly reverted somebody from SVT back into sinus rhythm, but then they go back into SVT, you don't then increase the dose of adenosine. You can if you want, but it won't make any difference. It's a misconception to think that a higher dose of adenosine keeps you out of SVT longer than an otherwise effective dose of it, but lower dose of adenosine. Adenosine is not an antiarrhythmic in that sense. It blocks the AV node to try and reset the heart and get you and to block the pathway and to get you back into sinus rhythm. What do you do if the baby is shocked? Sorry, is not shocked, but in congestive heart failure? And this is a relatively common one that you're likely in your career to come across. We say a baby because for the same reason we talked about atrial flutter presenting when they're sick. The first time that a baby presents with SVT is likely to be when they are at their sickest, because it won't have been recognized. Babies don't tell you that they've got palpitations, and they may well have been in it for hours and hours on end over periods of days or even weeks. And when they arrive, they may have an enlarged liver, be pale, and be short of breath and pretty oedematous. But that doesn't mean that they need a DC shock. But the adenosine by itself may not be enough to get them out of it, or it may get them out of it and then they go straight back in again. In that instance, I mean, an esmolol infusion is certainly a possibility. Being a beta blocker, and if you haven't seen the echocardiogram, you may be not completely sure about the cardiac contractility, and also esmolol does tend to make the blood pressure a little bit saggy. In its favour, it's very quick acting and therefore very safe. Once you turn it off, it's out of the system within a few minutes. Digoxin is not negatively inotropic and also doesn't tend to affect your blood pressure. But people are not so used to using it, and the dose does need to be adjusted if there are other comorbidities such as renal dysfunction. and especially if you've already used amiodarone or you were thinking about amiodarone, you need to be careful using those two together. But I would sometimes think about an IV loading dose of digoxin for that reason, and then going back to the adenosine. Ultimately, it's never very wrong to use amiodarone as an IV loading dose. It doesn't necessarily commit you to months and months of amiodarone. And being the domestos of all antiarrhythmics, it's probably the most effective. But if you were sort of winning, getting stuck in with a loading dose of IV amiodarone without running that past anybody, won't necessarily go down that well. And as I've indicated before, once you've given one of these antiarrhythmic treatments, the longer acting ones, you're more likely to be successful in cardioverting with adenosine. Doing 2 or 3 of these things can take several hours by the time you send ECGs backwards and forwards to cardiologists, and the patient might be starting to get a bit saggy and really need to get out of the SVT sooner rather than later. And certainly if amiodarone hasn't worked, then I would consider a DC cardioversion. Most times you have enough time and leisure to involve an anaesthetist and go to theatres, and indeed even the induction of anaesthesia usually gets patients out of refractory SVT, but you might need to do a synchronized DC cardioversion. In this instance, 0.5 joules per kilogram often works, but the guideline says 1 joule per kilogram. So keeping out of SVT, as I said, adenosine just gets you out of it. It doesn't keep you out of it. In most cases, a beta blocker is good first-line treatment. So in a baby, propranolol. In an older infant, after a few months, and certainly in a child, more likely to be atenolol. But if you need IV treatment in the short term, the beta blocker to use is IV esmolol. You can use metoprolol, but esmolol is so short-acting and comes pre-prepared. Or you could use digoxin or even amiodarone, but I would be doing that in consultation with a cardiologist. So moving on then to broad complex tachycardias. The ones that would spring to mind obviously would be ventricular fibrillation and ventricular tachycardia. These are very rare, certainly in early childhood. Ventricular tachycardia can be a bit more common in teenage years. But what's more likely actually is the patient has SVT with aberrancy. That's either they have Wolff-Parkinson-White and they have antidromic conduction, i.e. the Wolff-Parkinson-White pathway is being conducted down that and then back up through the AV node, or it's going so fast that the AV node has struggles to keep up and broadens out a little bit with the SVT. Or somebody who's known to have right bundle branch block and gets SVT will also have a broad complex tachy, or even sinus tachycardia in patients with right bundle branch block can be quite difficult to distinguish as well. So the history is very important here. As I said, ventricular tachycardia and fibrillation are very rare. So if you have a history of past cardiac surgery, that's obviously very important, both in the setting of having right bundle branch block, so therefore it may not be that big of an issue, but you are more at risk, especially patients who, for example, had repair of atrial flutter or truncus arteriosus. Those type of conditions are more at risk of ventricular tachycardia. Is there a history of Wolff-Parkinson-White syndrome? What medications are available in the house? And is there a family history of sudden death, cardiomyopathy, channelopathy, those type of things? So just keep it clinical again. You can see we have here a 13-year-old girl who's presented to the emergency department with palpitations. She feels very well. The palpitations last maybe 45 minutes at a time when they come. And she's not really she certainly hasn't been syncopal, very occasionally pre-syncopal, and this has been going on for several months. So what you can see is that you can see a broad complex tachycardia. The rate is approximately 150 beats per minute, and you don't see any P waves. It's monomorphic, and you can see it's got a left bundle branch block. So it's got a right bundle branch block pattern. So this is ventricular tachycardia coming from the left ventricle. It's probably left vesicular ventricular tachycardia, which on the whole tends to be quite a stable type of tachycardia. But in this case, it's not that you're going to send the girl home and tell her not to worry about it. but you don't necessarily need to get cracking with, you know, DC cardioversion. That would be crazy, and somebody sitting staring at you. But you're going to admit them, put them on a monitor, talk to paediatric cardiology. And if you're in a district general hospital and it's difficult to get hold of us, this is well within the realms of an adult cardiologist. In fact, they're more used to treating ventricular tachycardia than any paediatric cardiologist, with the exception of an electrophysiologist. Stop. But the likely treatment for this will be a beta blocker, and sometimes in the future an electrophysiology study. So in this instance here, this could be the same history, but the heart rate's a little bit faster, 160 beats per minute in this case, monomorphic. But in this instance, there is left bundle branch block. So this is right ventricular outflow tract tachycardia, and this tends to be a fairly benign type of ventricular tachycardia as well. Again, this is taken in the context of an otherwise well girl or boy who doesn't have congenital heart disease, and there's no strong family history of note. So you have to factor all those things in as well in terms of your initial assessment. These patients are all going to end up getting an echocardiogram, Holters, and I would again treat this with a beta blocker. You could treat this with a calcium channel antagonist as well. Whereas this ECG is obviously very different. And where you have here is very disorganized, very fast, broad, complex tachycardia, and this is ventricular fibrillation. And obviously this patient is not going to be walking off the street and telling you that they feel a little bit dizzy and have palpitations. This will be a cardiac arrest rhythm, and you'll just follow the APLS guideline. But ultimately, these patients are going to require shock. This is obviously an AED, but they need DC cardioversion. Just a couple of other ECGs to add a bit of interest. You can see here that there is broad complex, relatively tachycardia, but 150 beats per minute again. But there are two distinct QRS morphologies, 1, 2, 1, 2, 1, 2. So it's alternating. This is called bidirectional ventricular tachycardia. Now, it's not that you'd be blasé about this anyway, but this is specifically associated with CPVT, catecholaminergic paroxysmal ventricular tachycardia, and it is one of the leading causes of sudden cardiac death in young people, mostly in the second decade of life, but it can be even a little bit earlier than that, but mostly in the second decade of life, and one of the leading causes of sudden cardiac death with exercise. So this is if you saw this, you'd certainly be admitting the patient and talking to us, and you'd be very worried about the patient as well. And this will need immediate treatment. If the patient's sitting staring at you, you don't need to do an immediate DC cardioversion, obviously. So, sort of looking through the APLS guidelines, if somebody has a broad complex tachycardia, which you're not sure what it is permissible to try adenosine. Patients with ventricular tachycardia may well be looking at you not particularly symptomatic. So if they are, don't panic. But do contact us. You can send an email or text the ECG to a friendly paediatric cardiologist. You could try magnesium sulfate. That can make you a bit hypotensive, but it's generally a very safe antiarrhythmic for ventricular arrhythmias. If on the advice of the paediatric cardiologist they think this is a fairly benign type of ventricular tachycardia, then you could try beta blocker. But if the patient is symptomatic and you're worried about them at all, and there isn't a very clear history of long QT syndrome, then loading with amiodarone may well be the appropriate thing to do. If you can't get them out of it and they're starting to get sick, then a synchronized DC cardioversion, which will likely require the help of a general anesthesia, may also be appropriate. Obviously, if it's unstable ventricular tachycardia or the ventricular fibrillation, then you strictly follow the APLS guideline on that, which is here for your benefit. And I won't go through that right now. So, too slow. So we've covered all the tachyarrhythmias at a gallop. On the slow side, tend to be a bit more relaxed about that, although it causes a lot of questions for a paediatric cardiologist. But slow heart rates, are less likely to make you symptomatic and much less likely to be associated with sudden cardiac death. The majority are just sinus bradycardia, which is usually physiological. If you look at that table that I gave at the start, many patients fall below the recommended heart rate for their age, and therefore by definition they have sinus bradycardia. But that doesn't mean that they've got something wrong with them. So they may just be a very fit, healthy young person. Changes in vagal tone can induce sinus bradycardia as well. And I suppose you want to be sure to yourself that they don't have increased intracranial pressure, but there should be other signs of pathological things causing increased vagal tone. Does the patient have access to medications that they shouldn't have, such as digoxin? Beta blockers would be more common, obviously, and antidepressants. And then, is it actually sinus, i.e. is it coming from the sinus node, or is it coming from an ectopic atrial pacemaker? So if you look at lead 1 and lead 2, it may well be, lead AVF, it may well be downgoing and therefore coming lower down in the atria in the coronary sinus, and that would be the most common ectopic atrial pacemaker. But that's really basically physiological as well. Or is there sinoatrial node disease? So are there big pauses? Is there sick sinus syndrome? So tachycardia followed by bradycardia inappropriately. And those things do require ongoing monitoring and occasionally a pacemaker. I just put in sinoatrial node exit block really for completeness. You won't see it. I've never seen it. For all of those things on the bradycardia side, which are coming from the atria, a really important thing is how many symptoms are there, how pervasive are the symptoms, and is there chronotropic competence? Then it could be coming from the AV node, and that is a more important source of pathology for causing bradycardia. If there's AV block, it can be first, second, third degree, which we all know about. First degree AV block is basically physiological, and they should have a normal heart rate. Second degree AV block has two types: Mobitz type 1, which is wanky back, that's drop beats, whereas the Mobitz type 2 is where there is a fixed relationship, like 2-to-1 AV block, 3-to-1 AV block, and so Mobitz type 2 along with complete heart block or third degree AV block are totally different from the others. This is high grade AV block, which is definitely pathological and is much more likely to require a pacemaker in the long term. What also adds into the mix in terms of how seriously you view these things, how much investigation they're going to get on the threshold for pacemaker insertion, is whether there's a history of congenital heart disease or previous cardiac surgery. So here we have a 3-year-old boy attends the emergency department having fractured his humerus. The nurse notes that his observations are relatively slow, especially considering that he should be in a fair amount of pain, but he denies any other symptoms. So what you can see here is the QRS complex is pretty regular. It's about 70 odd beats per minute. And there are P waves, but the PR interval, well, there's P here, P here, P here, P here, P here. When you measure out the P interval, it's constant, but the PR interval isn't. And there's obviously more than one P wave for every QRS complex, but it's not always the same number of P waves. So really, when the best way of doing this is to get a sheet of paper and mark on the P waves and then slide it across to make sure that works. And then doing your PR, doing the same thing for the PR interval. That's how I work out what type of heart block it is. And what you'll see here is that really there is no association between the P waves and the QRS complex. This is complete heart block. So what would we do now? Well, this does not by itself necessarily need any treatment if he's not having any symptoms. So we'll look at the European guidelines for pediatric permanent cardiac pacemaker in a minute. But you have a narrow QRS complex. You don't have any wide ectopic QRS beats, and the heart rate is in the 70s. So on the face of it, this wouldn't require a pacemaker. But would need a workup as to why this has happened. Was this congenital? Has he had evidence of myocarditis? Is there a family history of this? Has he got a structurally normal heart? What's the function of his heart like as well? So it's not that obviously this patient is not going to get followed up, but they don't necessarily need any immediate treatment. The only blind point would be, how did he fracture his humerus? Was he syncopal and then he fell, or was he playing football or fell out of a tree after having swung on it? So the history is important here. Whereas this ECG here, you can see again there's complete heart block. So P, 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 and the PR interval changes, and there's no association between it and the QRS complex. The QRS complex is nice and narrow again. There don't seem to be any other QRS morphologies, but the rate here is a lot lower. The rate here, about 7 and a bit boxes between the RR interval, and so the rate here is in the low 40s. And this in a child would score you a pacemaker. Here we can see P dropped, P QRS, P QRS, P dropped, P QRS, P QRS, P dropped. But if you look at the P interval here compared to here, it's shorter here than it is here. So this is quite clearly wanky back, which is Mobitz, second degree AV block, Mobitz type 1. And this is a relatively benign thing. In fact, most of us would have this during sleep. Having said that, again, you're going to investigate this to make sure there aren't higher grades of AV block going on at the same time. Completely different from Mobitz type 2, where you have here 1 P wave QRS, P, P, QRS. So two Ps per QRS, but it's much slower as well. And the QRS complex is pretty wide. This is pretty nasty stuff, actually. And in this case here, not only is this child going to get a pacemaker, but actually this child, in this instance here, requires emergency temporary pacing, I would say, because the heart rate here is about 30 or so. Whereas in this instance here, you have P, P, QRS, P, P, QRS, P, P, QRS. So there's a 2-to-1 AV block, but the heart rate here is about high 60s, 70s, something like that. And this patient is much less likely to be symptomatic, but it's still high grade AV block. So they may well end up with a pacemaker at some point down the line, but we'll just need further investigation and monitoring. So moving away from AV node disease to sinus node disease. So this is the Holter monitor of an 8-year-old girl who has severe learning difficulties, but she had a syncopal episode in the paddling pool. And so this occasioned quite a lot of Holter monitoring. And now she wasn't symptomatic when she had this, but there's a 4.8 second pause followed by a 3.5 second pause. And this girl ended up getting a pacemaker. And the reason for that was because of this symptom of syncope in the paddling pool. And she had other reasons for having brief episodes of loss of consciousness. But if I could rationalize that a pause like this could have happened in the paddling pool, then she could have died from drowning. So it's not that sinus node dysfunction by itself is very, very unlikely to kill you because of cardiac standstill. But if you're doing something that you then would become syncopal and injure yourself as a reason for that, then that might be a reason to put a pacemaker in. And that would be effective at stopping those pauses. So these indications for a pacemaker, and this is in congenital AV block. This is just for your own reference. There aren't really any definite guidelines for pacemaker insertion in sinus node dysfunction in children. For some things, for example, in reflex anoxic seizures, where you will also get a sinus pause, I mean, people would be just as likely to let you have a pause for at least 10 seconds before considering putting a pacemaker in. But the frequency and the nature of the symptoms do play a part in whether or not you put a pacemaker in. Some parts of the guidelines would suggest that if you have a pause for over 3 seconds and it's sinus node dysfunction, that you're and there is general evidence of sinus node dysfunction, that you may warrant a pacemaker. This is just for your benefit to see somebody who's got long QT syndrome. You can see that there is a long QT interval here, and also this upsloping is very typical of long QT type 1. And just to measure the the QTC. It's usually using Bizet's formula. Don't just read the computer-generated printout. Actually measure the QTC. So just to summarize, it's important that you take time to look at the ECG, recognize the rhythm, but equally important to look at the patient's condition. How quickly do you need to act? And that's as important as what you need to do, i.e. what specific therapy. In SVT, adenosine is usually therapeutic, but it can be beneficial in terms of uncovering the rhythm even when it's not therapeutic. Nearly all types of SVT will benefit from beta blocker. In terms of broad complex tachycardias, much rarer. They're much more likely to make you sick, but they're not always. So you don't necessarily have to panic, and that's why I say you should always look at the patient. Contact pediatric cardiology. You may try intravenous magnesium sulfate. If the patient's very well, you could try beta blocker, but if the patient is symptomatic or is decompensating in any way, then amiodarone is more likely to be beneficial, and in fact, you may even need to do a DC cardioversion. Bradycardia is much less likely to be fatal, much less likely to cause symptoms, to actually cause the symptoms. Patients may be symptomatic and be bradycardic, but those are two different things. If it's AV node dysfunction, though, that is important if they are symptomatic and have evidence of certainly of high-grade AV node dysfunction. Sinus node dysfunction is relatively uncommon, but certainly does happen in young people and is very rarely fatal. But it can result in the insertion of a permanent pacemaker. Thank you very much. Happy to take any questions.